Welcome, everyone. My name is Malcolm Bell. I'm the Vice Chair of the Department of Cardiovascular Medicine here at Mayo Clinic in Rochester, Minnesota. And this is another in our series of interviews with the experts. And so today I'm very pleased to welcome again my colleague, Dr. Jörg Herrmann, who's here to answer some questions about COVID-19 in cardio-oncology. Jörg, welcome.
Thank you so much, Dr. Bell, for the introduction and the invitation to be here.
Yeah, it's a pleasure. I think that you got some unique comments to make here. So, as we think about the title of the talk, we're talking about COVID-19, cardio-oncology, which is obviously heart disease and oncology, treatment of tumors. How do these three come together? Why are we talking about these three together?
Well, they're not only the top three causes of death in the US as of 2020, when you look at the statistics, but a year ago, when the COVID-19 pandemic started in China, it was recognized relatively early on that patients who had underlying cardiovascular disease or cardiovascular risk factors were at the highest risk of developing a severe course and even dying from COVID-19. So that was the first wave of publications we've all seen. And then the second wave of publications, literature that came out, was then indicating that cancer patients also had a higher risk of a severe and fatal outcome, dying from this very pandemic. And so this is where things then started to come together. People started, colleagues of ours started to look at cancer patients in particular, and they found that those who survived and did not survive, what made the difference? And it was the extra diseases they had. We call these comorbidities. The ones with heart disease on top of cancer, malignancy, and or cardiovascular risk factors were the ones at highest risk of a poor outcome. So that's really what sparked the interest and the overlap in these, the top three, as said, the top three killers, even in the US as of 2020.
Now, cardio-oncology is a small specialty, but an important specialty in cardiology. So that connection between cardiac disease and an underlying tumor or the result of treatment of a tumor, that's something that you were involved with and researching and treating before the pandemic. That connection between the two is still obviously important. Has it become more important during the pandemic?
Yeah, right. And so it's a great testimony, if you will, to the advances in medicine and the success that's been accomplished since the 1990s. Cancer-related mortality, the death rate due to cancer, has really declined steadily. And now we're looking at nearly 20 million survivors of cancer in the US alone. And what really was not an issue decades ago, that is the long-term outcome, how do these patients fare and how do they deal with the side effects of the therapy, has really become a very prominent topic. And it's not trivial. In fact, quite the opposite. If a cancer patient's developed a cardiac complications because of their treatment, that can end that treatment, and obviously with grave implication, or for instance, if they develop heart failure, the prognosis of heart failure, what to expect and life expectancy and so forth, could be worse than even for the cancer they were treated for. So it is something really impactful, and that's now in everyone's mind, and that's right. Where not only here but everywhere, this is rising.
Yeah, and certainly for the patients. So how has the care of these patients changed during the pandemic, the COVID pandemic?
Yeah, as you remember, last year was really for us, but also for our colleagues in the US, New York, Europe, China, such a change in practice, and outpatient practices were shutting down. We tried to shield everyone, redistribution of resources, and that had, its impact, because the usual aspects of this particular intersection, which has a lot to do with monitoring, where we take care of the patients before, during, and after their cancer therapy to make sure that we're preventing complications, dealing with complications early. That really got compromised. And so a lot of this has to do with inpatients, we wouldn't say, but with in-hospital or in-office evaluations, echocardiograms in particular. But now we've switched into more remote monitoring, telemedicine, but also looking at technologies that would allow us to monitor the patient without for them to come in, or using biomarkers, blood markers, where we measure and follow these patients more easily. So that's the shift in thought there as far as how do we monitor these patients.
I mean, obviously, there were concerns about patients delaying, presentation, maybe even delaying initiation of treatment, or maybe being hesitant about reporting side effects, if, because they were, had that concern about stepping into a healthcare facility during the pandemic. With respect to remote monitoring, what sort of things did you see being put into place there?
Yeah, so I mean, obviously, if some patients on some particular cancer drugs, they can have high blood pressure, and then I mean that's something like a blood pressure cuff patients often would have. Now, what we've been our interest has been in using a mobile ECG, where patients just have a little device where they can put their fingers on and will transmit an ECG. Those kind of tools are being investigated and show some promise. So if there's a silver lining out of this COVID-19 pandemic, and others have seen it in other areas, I think there will be something that really got catalyzed and propelled in the development and can be utilized even after the pandemic. I think some aspects of the way we deliver care might have changed forever.
Yeah, in fact, we're very fortunate. We've got some really innovative colleagues here who've been heavily involved with developing AI, artificial intelligence interpretation of some of those simple ECGs you're talking about. I know that you've been involved in some of that work. Where do you see that going? And maybe you could explain some of the things that we've been looking at and how they may become so important.
Yeah, I mean, it was Dr. Friedman, Dr. Ty, Dr. Noseworthy, and I mean, really a great group of engineering and genius ideas and work, which we've now implemented to these cancer patients, because some of it is common, reduced heart function, for instance. Those are some of these aspects that's been investigated. And actually, we have the tool available to pick it up in a general population, and are now investigating how is this working in cancer patients, where you actually know more or less when the time of injury and time of onset of heart damage, if you will, is occurring. So it's even more concrete and focused. So I think we feel that I think there's high promise for this. But we need to evade the studies.
Sure. You were telling me earlier that you chaired a session in Israel. Was it last year? And in terms of what lessons we've learned in these patients with cardiac issues in patients with cancer. What were the take-home points there that you'd like to emphasize?
Yeah, I think, I mean, the lessons were, as we were looking back, group of us, and pondering on this pandemic and the implications, I think number one, we've learned that we're all very vulnerable as a society and as individuals. And heart disease patients, cancer patients, I mean, that is something and really resonates with this field of cardio-oncology, as we talked about earlier. And then prevention really is the best medicine. I mean, with the COVID-19 pandemic, I think that's really one of the key points, and so crucial to not forget this, because we're all getting tired of some of the measures. But to prevent it in the first place is better than trying to do anything after. And that's so true, I think, in many areas. And then the other was what we call get with the guidelines. We have, groups of experts, as you know, and you're part of expert panels, and really trying to synthesize bring together the evidence and formulate recommendations. And I think what you mentioned it earlier, what we've seen too in this COVID-19 pandemic is the shortfall of this, if you're not following this. And if individuals are getting very scared, I mean, if patients do not call 911 when they have a heart attack or a stroke, when they have delays, the same for cancer therapy. I mean, that can be profound. And then also, I think the nice aspects of this was how we can all work together. I mean, the research that has occurred, the vaccine development, when you just look at that, it's just phenomenal. And if we're really communication and collaboration across the globe, across disciplines, I mean, different fields in medicine, I think it's really phenomenal what we can do if we want to do it.
Jörg, I think those are some excellent observations, and we've probably got many patients who are viewing this. So maybe just in the last 30 seconds, what advice would you give to patients with cardiac disease who have cancer or one or the other in the time of a pandemic?
Yeah, I think number one, I would say be aware of the pandemic and do all the precautions you can do. As said, prevention is the best medicine. Vaccination, I think there's still a lot to be said for this, as far as the benefit outweighing any potential risks. And then not to forget about the underlying diseases, let it be heart disease or let it be cancer, they still need to be treated. And if there are symptoms of a heart attack, I think the hospital still is the best place. I think it's still safer than some of our supermarkets, to be honest, to go to in terms of the infectious risks. So I think that's extremely important for patients to know.
Well, that's excellent advice for all of us. And again, I want to thank you for your time and you're joining us today. And I'm sure our viewers have found this really very interesting and very helpful. So thanks again, Jörg.
No, thank you so much for this invitation and making this possible.